Okay, thanks very much. I'm delighted to see that most of you hung on. When I seen my name in the brochure and it was very end, I said, oh my God, they put me at the end because they expected everybody to be shooting off as quick as possible. So it's a little bit of a relief to see everybody here. What I want to talk about is, I want to just give you some basic tools and also to discuss the importance of not just airway, but flow. Because airway gets all the consideration in an obstructive sleep apnea. How open is the airway? But I think it's just as important to be considering what's the volume of air that's passing through that airway. We need to look at the relationship between breathing and airway size. Now, many people feel that, breathing is an involuntary activity. It's not subject to change. But breathing changes, and it changes very much. It changes from, and possibly it's passed down through genetics, that there's a genetic predisposition to how we breathe. And there's also mirroring how we breathe based on our parents. Lifestyle factors, especially modern living, including stress, also influence breathing. And we develop habits, such as dysfunctional breathing patterns, and none of these jump out at you. These are very, very simple things. These are, habits that you see with your clients and patients all of the time. And yet, they never get much consideration. So the child or adult that walks into your surgery with the mouth open, or the individual who's having a sigh every now and again, or the person who's breathing, you hear they're breathing at rest, or somebody who is regular sniffing, or if they're yawning considerably with large breaths, upper chest breathing, or noticeable breathing. That's what we look at. And if we see that taking place, alarm bells go off. Because the harder you breathe, the less oxygen that's delivered to the tissues. And what I'll impart to you is, we will do simple exercises and to see, is there a change in your own physiology as a result of doing the exercises? Can we show you how to decongest the nose? Can we show you how to open up your blood vessels? Can we show you how to open up the upper airways and the lower airways? And can we show you a relationship between breathing and OSA? And before we consider it, we have to consider, when I was flying here, there was a guy behind me fell asleep on the plane, and I was listening to his breathing. And it wasn't light, it was heavy. Can you snore and have light breathing? When you're listening to somebody snore, how are they breathing? Their breathing is relatively fast. It's noisy, and it's a large amplitude. There's no pauses between breathing. Because as soon as the person breathes out, they have to breathe back in again. It's noticeable breathing. And how we breathe during the day determines how we breathe during our sleep. If you have dysfunctional breathing patterns during the day, you cannot automatically expect them to change or to improve during sleep. But we can change our breathing during the day. And by changing our breathing during the day, we can change our breathing during sleep. Do people with OSA breathe lightly? How do you breathe when you're stressed? Look at the breathing of people who are sick. Light breathing is healthy breathing. If you were going for a run alongside an elite athlete, that elite athlete will have light breathing for their given level of physical exercise. We all breathe differently. And breath hold time is just a simple measurement. When we're looking at what I'm doing is, we have a measurement called the control pause, which we use in adults. It's basically the length of your comfortable breath hold time. And it's a very good measurement of breathlessness. And it also gives you some feedback of how the individual is breathing. So we look at the individual, we pick up on how they're breathing, and we also use breath hold time called the control pause. If the control pause is less than 20 seconds, main symptoms are present, including nasal obstruction, asthma symptoms, coughing and wheezing, snoring, and OSA. But OSA, it'll obviously depend on genetic predisposition. But the lower the breath hold time, the harder the person breathes. And there's been quite a number of studies showing the relationship. I only put up one, but there's many studies looking at, well, certainly I have 6 or 7 of them, looking at the relationship between breath hold time and dyspnea. How hard is the person breathing? The harder you breathe, the lower your breath hold time. They've looked at it with cystic fibrosis. They've looked at it with severe asthma. This one here looking at it with COPD, but they included asthma here. That there was a direct relationship, that the breath hold time was considerably lower in COPD, and they included asthma in this instance, than in controls, and that these measures correlated positively with spirometry readings. So breath hold time is a measurement that you can have, in simple terms, look at how your patients breathe, sit them down for 10 minutes and measure how long do they comfortably hold their breath for on the exhalation. The lower the breath hold time, the harder they breathe. The harder they breathe during rest, the harder they breathe during sleep. Straight away. Very simple measurement, non-invasive, and it will give you some feedback. And when we're talking about oral breathing, it's so common. It's actually endemic. Over the last few years, it's received widespread attention. Mouth breathing, I've looked at books that have been written since 1903. There's one even before that written by an American painter called George Catlin, and he wrote that in 1872. And the book is called Shut Your Mouth and Save Your Life. And he went and he lived with American Indians because he thought that the traditions of the American Indians were dying out. So he went and lived with them, and he painted. So he documented their history by painting. And in that book, he noticed that the American mothers, the American Indians, the indigenous population, that when the baby had the mouth open during sleep, the American Indian mother would go over to the baby and press the lips together. And he said this was brilliant. And he said the Europeans coming over, and he said the children sleeping with their mouths wide open on their backs, gasping for breath. This was written back in 1872. Mouth breathing is now endemic. This study here, 55% children habitually mouth breathing. Randomly sampled selection in a town in Brazil. They enrolled 370 children, clinical assessments carried out, 55% mouth breathers, 45% nose breathers. This study here, looking at children in Portugal, aged between 6 and 9, 496 answered questionnaires from parents, 56.8% of children mouth breathers. This study here, 150 children. They did 2 tests. One is to breathe steam against a mirror, the fog test. And the second was, which is quite a useful test because there's no discernible test to determine mouth breathing and nose breathing. So they had children take a sip of water, take a mouthful of water, and see if the children can hold on to the mouthful of water for 3 minutes. If you can hold on to the mouthful of water for 3 minutes, you were classified as a nose breather. If you couldn't, you were classified as a mouth breather. They found that 53.3% were mouth breathing. This study here, Japan, questionnaires from parents. They asked the question if they had more than 2 positive items amongst the 3. If the child breathes with a mouth open, if the mouth is open ordinarily, and if the mouth is open when chewing. I was a mouth breather when I was a kid, and when I used to go to families or friends and have dinners, I remember that I'd be admonished for chewing with my mouth open. Of course, my nose was constantly blocked. If your nose is constantly blocked, you can't do much else but chew with your mouth open and breathe through it. And in this instance, they found, they looked at 2 more positive outcomes. If the child is snoring, you can snore with your mouth closed. Like, you can snore through your mouth, or you can snore through your nose. Two different things. So it doesn't necessarily indicate mouth breathing, but it would certainly indicate dysfunctional breathing. If the mouth is open during sleeping, and if, of course, the mouth is dry when the child gets up, and the same would go for the adult. So they found here that it was the prevalence in Japan during the day was 35.5%, and during sleep was 45.9%. But this study was looking at the relationship between mouth breathing and atopic dermatitis. The relationship between mouth breathing, how you breathe, can influence many, many aspects. And I'm not saying that this is a cure-all or anything like that. But mouth breathing is stressful to the individual. Nose breathing is the key. You all know that the nose is not just the 2 holes in the face. even the simple basis of nitric oxide that's emanating from the paranasal sinuses, and with each breath you take, you're carrying nitric oxide into the lungs. Nitric oxide improves ventilation perfusion. It ensures that the ratio of air meeting the ratio of blood is equal. Generally, when we breathe, we hyperventilate with the upper part of the lungs. But with gravity, the concentration of blood is in the lower part, so there's a mismatch. And nasal breathing, harnessing nitric oxide, ensures that blood is distributed more equally throughout the lungs, and there's a better gas exchange takes place. It's estimated that when you breathe using your nose, that your oxygen uptake is 10 to 20% higher than with your mouth. Mouth breathers is not healthy. And mouth breathers show, this is just for children, I just throw this in, I know it's not related, but you know what? I tell parents this because parents want their children to do well academically. And if you can show, and this is being studied now, this is a relatively recent paper, 2014, and most of the research is coming out of Brazil. For some reason, most of the research is coming out of Brazil. Mouth breathers show cognitive impairment as well as attention deficit hyperactivity disorder, memory, concentration, attention, learning disability, low perception, and sensor and motor integration. It has been shown that children with excessive daytime sleepiness appear to have almost 10 times the risk of learning difficulties. This is motivation for parents when the children are coming in with their mouths open. If you say that there's an increased risk of poor academic performance, it's enough motivation, aside from the craniofacial changes that you're all aware of. So there's no study that I have came across linking how many adults mouth breathe. I have never came across a study. I've been trying to find a study. I'm sure Chris Bowman down at the back of the room has been doing likewise. Maybe you have been doing it. If you find a study showing the prevalence of mouth breathing in adults, please let us know. We are dying to hear. This is the nearest that I've came across, the European Respiratory Journal 2008, that they show that the percentage of fraction of breathing averaged 7.6% during wake and 4.3% during sleep. And I have to say, I do not believe those figures, because I think it's far, far more prevalent than that. The amount of people that come into me, and we have a typical questionnaire. I've seen thousands of individuals since 2002. I've asked them the questions: do you wake up with a dry mouth? Do you snore? Have you ever been told you hold your breath? But the amount of people that wake up with a dry mouth in the morning is very, very common. How many of you here, you don't have to show me your hands by the way, how many of you here wake up with a dry mouth in the morning? If you wake up with a dry mouth in the morning, it's a pretty sure thing that you're having your mouth open during sleep, that you're mouth breathing during sleep. So the relationship with sleep disorder breathing, we have to consider snoring. What is it but the exchange of a large volume of air through a narrowed space? Two things are going on here. The exchange of a large volume of air. If we breathe heavy during the day, we breathe heavy during our sleep. And the second aspect is the size of the space, the diameter of the airway. We cannot consider one without the other. Can you imagine a plumber coming to your house, and the plumber has to determine the diameter of the pipe bringing water from, say, one aspect of the house, one part of the house to the other? Can you imagine the plumber just choosing the size of a pipe at random without considering the amount of water that's expected to go through it? The two go hand in hand, and with breathing, they also go hand in hand. Large breathing volume, narrowed space. Two types of snoring. Snoring with the mouth open. Very easy to address. All you have to do is get the mouth closed. The second type of snoring is high upper airway resistance, turbulent airflow in the nasopharynx. It's the more difficult one. We show people how to decongest their nose. We show people how to bring their breathing volume down towards normal. No devices, no gadgets, just simple feedback. We look at an individual's breathing and we give them simple breathing exercises, which we'll practice as a group. And I'd really like you to practice them, because I can talk about them, but until you experience the effect, You know, it gives you a better perspective of it. And of course, the next progression is obstructive sleep apnea. Normal minute volume, if you were to look, this is a 2009 book, if you were to look at normal minute volume, it's 4 to 6 litres of air per minute. So generally we have 10 and 12 breaths, each breath is half a litre, and that's giving us our 4 to 6 litres of air. That is considered normal. But when we look at asthma, and the reason that I'm bringing up asthma is because I'm going to tie in asthma with obstructive sleep apnea. There is something going on with asthma that's also going on in OSA. And we have to find out why. What is the relationship? But people with asthma are breathing between 10 and 15 litres of air per minute. Now, as Omer pointed out earlier on, he says, we live without food for weeks, we live without water for days, we live without air for just a few minutes. You all know how much food you should be eating every day. You all have an idea how much water you should be drinking. But how much air should you be breathing? Is it healthy to breathe 2 to 3 times the volume of air every minute, every hour, every day? In a medical textbook, normal breathing is considered 4 to 6 litres of air per minute. That's here. If somebody walks into a doctor's surgery and they're having a panic or asthma attack, they can be having 20 to 30 litres of air per minute. That's here. That's recognised. Normal breathing is recognised. Excessive breathing is during a panic attack is recognised. Nobody is looking at the piece in the middle. If you get very sick in the short term by breathing 20 to 30 litres of air per minute, well, my question is, well, if you're breathing 2 to 3 times more than what you should be, every minute, every hour, every day, are you also going to get sick? And it's not just that asthma is causing overbreathing. It's the feedback that overbreathing is literally sucking moisture out of the airways and causing inflammation to feed back into it. There's a feedback loop. And I also believe the same feedback loop is with OSA. Never studied, very seldom, minute volume with obstructive sleep apnea. How much air does the individual breathe? In this paper here, they looked at 20 obese men with OSA and normal lung function. And they were found to be breathing 15 litres of air per minute. Minute volume, 15 litres. Normal is 4 to 6. They're breathing 2 to 3 times more. The next, in the same paper, 12.8. These people have overlap syndrome. They've got both OSA and COPD, but they're still breathing excessively. And when we look at OSA, we have to consider flow. I'm just going to play a short video.
Obstructive sleep apnea occurs when the upper airways collapse, resulting in holding the breath during sleep. After a period of time, the sleeper partially wakes up, gasping for air. This cycle of breath holding followed by gasping can occur many times an hour during sleep. In addressing obstructive sleep apnea, 2 factors need to be considered. The first is airway size, and the second is the amount of air that we habitually breathe. In relation to airway size, the narrower the upper airway, the greater the negative pressure as air is drawn into the lungs. Habitual mouth breathing during childhood can alter the shape of the face, resulting in small or receding jaws. This reduces airway size and increases the risk of lifelong sleep apnea. As we get older, loss of muscle tone in the upper airway also contributes to holding of the breath during sleep. To help open the upper airway, it is important not to sleep on the back and also to breathe through the nose. The second consideration in obstructive sleep apnea is the amount of air that we breathe. It is very common for people to habitually breathe too much air, as indicated by audible breathing often through the mouth. Heavy breathing during sleep increases negative pressure in the upper airways, causing collapse. Imagine inhaling a large volume of air through a collapsible paper straw. The heavier one breathes, the greater the likelihood of the walls of the straw collapsing inwards. On the other hand, breathing light through the straw causes less negative pressure, thereby reducing the risk of collapsing the walls. Breathing re-education to reset the breathing center in the brain to a lighter breathing volume significantly reduces the occurrence of obstructive sleep apnea. Combining this with myofunctional therapy to strengthen the upper airways enhances the benefits, resulting in a significant reduction in apneas and hypopneas.
Okay, so it would be based on the Bernoulli principle. And basically this states that as fluid flows, a negative pressure develops at the periphery of the flow. But most importantly, as flow velocity increases, so does the negative pressure. So the best way to imagine it is breathing through a paper straw, a collapsible paper straw. The upper airways is collapsible. If you breathe hard, you're going to cause negative pressure on the inner walls of the airways to cause them collapse. And the other aspect about this is that if positive pressure helps open up the airway, reducing negative pressure should also help ensure that the airway will stay more open. And the second factor of this is the Venturi effect, and this is looking at airway size. And basically, as a given volume of fluid moves through a conduit of decreasing diameter, the velocity of the fluid will increase. The narrower the upper airway, the greater the velocity. There's two aspects going on. We have the Bernoulli principle, which is solely looking at air volume, breathing volume. And we have the Venturi effect, which is looking at airway size. And when we look, what is obstructive sleep apnea? But collapse of the upper airway occurs if the negative upper airway pressure generated by inspiratory pump muscles exceeds the dilating force of these upper airway muscles. And that definition is taken from a number of papers looking at obstructive sleep apnea. Again, let's look at breathing. This here is what's called a Starling resistor model. And it's very interesting in terms of if there's an obstruction in the front of the airway vis-a-vis the nose, if the nose is blocked and if it's difficult to breathe through the nose, it will increase the negative pressure further on the airway. So we're talking about breathing volume. We're also talking about nasal obstruction. So it behaves like a Starling resistor in that obstruction at the inlet, the nasal airway, produces collapsing forces that are manifest downstream in the collapsible segment, the pharynx. So the basic message so far is breathe through the nose and breathe lightly. And when I was trying to put the connection together, because there is nobody putting the connection together, or very few of us, in terms of breathing volume and obstructive sleep apnea, I looked at asthma. And I asked the question, why with asthma, why do approximately 74% of asthmatics experience nocturnal symptoms of airflow obstruction secondary to their airways disease? The incidence of obstructive sleep apnea is generally recognized to be about 20 to 30% of the population. I know many people are undiagnosed. Why does it increase with asthma? Why is obstructive sleep apnea, hypopnea more significant, more prevalent with patients with severe compared to moderate asthma? That as asthma severity increases, so does obstructive sleep apnea. What's the relationship between the two? Asthma is inflammation of the lower airways, not necessarily inflammation of the upper airways. But as your asthma becomes more severe, how do you breathe? Does your breathing get lighter or does your breathing get heavier? If you had somebody walk into this room with severe asthma, how are they breathing? They will be out of breath, literally just walking into the room. If they were to sit down and rest for 10 minutes to recover, you will still see noticeable breathing. The more severe our asthma, the more we breathe. Our tidal volume increases and the respiratory rate increases. In other words, the number of breaths we take per minute increases, as does the size of each breath. In this here, 88% of patients in the severe asthma group, 58% of patients in moderate, and 31% in controls had more than 15 apneic events per hour. Again, what is the relationship between asthma severity and obstructive sleep apnea? 472 patients with poorly controlled asthma. In other words, if your asthma is under control, you'll have less risk of obstructive sleep apnea. If your asthma is out of control and you need more than 3 puffs of your reliever medication per week, it's considered that it's one of the factors that would deem poor asthma control, and it increases the risk. The question is, if breathing volume is brought towards normal, the negative pressure is reduced and apnea is reduced. Can we improve asthma control? And the other aspect to this is it that sleep disorder breathing is causing inflammation of the airways, or is it the fact that we're breathing too much, including mouth breathing, contributing to inflammation of the upper airways? I'm sure that you've often been out one night and you've had a few drinks of alcohol and you've come back and heavy breathing as a result of alcohol and muscles relax. And you wake up the next morning and your throat feels totally raw as a result of it. All that heavy breathing in and out of your mouth, your throat is raw, your throat is inflamed. That's an exaggerated example. But when we breathe heavy, it does contribute to inflammation of the upper airways. So here's the tie-in again. Over-breathing, mouth breathing, causing inflammation, and inflammation causing narrowing of the airways, Bernoulli effect and Venturia principle. And yes, there is a relationship between our breathing and inflammation of the airways. I took this from the New England Journal of Medicine. It's an article called Hypocapnia, and basically it states that airway hypocapnia, which is causing smooth muscle contraction, increased amounts of mucus, causing airway resistance, increases the work of breathing, increases the sensation of breathlessness, feeds into hyperventilation, which feeds back into airway hypocapnia. The carbon dioxide model is a little bit controversial. However, the cooling and dehydration effect of the airways is not necessarily controversial. It's accepted. People with asthma don't just breathe heavy because of their condition. Their heavy breathing is feeding back into the condition. I'm just going to show a brief video to show you.
Habitually breathing too much air into the lungs contributes to the cooling and drying of the airway walls. Depending on genetic predisposition, this can cause the airways to inflame and narrow, resulting in wheezing, coughing, and breathlessness. When breathing volume is changed towards normal by breathing through the nose and practicing to breathe light, the airways re-expand, resulting in significant reduction of asthma symptoms, improved asthma control, and a reduced need for medication.
So in terms of improving asthma control, this was a clinical trial that took place in Calgary. It was 2008, and basically with the Buteyko group, asthma control, which is normal, 40% of the asthma population having their asthma under control is normal. It improved asthma control from 40 to 79%. Now the control group, a physiotherapist came in from South Africa, and she taught reduced breathing with relaxation, and she also achieved a great asthma control. When you bring in reduced breathing and relaxation, you reset the respiratory center in the brain, and as a result, breathing becomes lighter. Now, the main difference here was that the Buteyko group had significantly less need for inhaled corticosteroid. My point here is there's a relationship between asthma control and obstructive sleep apnea. When you change breathing, you can improve asthma control. And by virtue, we should be able to improve obstructive sleep apnea, but it's never been studied. We have minute ventilation, the amount of air that an individual is breathing during rest, and the amount of air that that individual is breathing during their sleep. And the question to ask is, what would happen if we changed their breathing volume more towards normal? To reduce negative pressure, could we reduce the AHI index? Now, I have worked with thousands of individuals and I have seen the changes, but that's only anecdotal evidence. There's no point in me talking about it. And by the way, I came from a history of asthma and obstructive sleep apnea. So I work in this field primarily because of the effects it had on my own life. And it had a huge effect. And I'm not just that subject or the case. You know, I had 25 years of it. And that gives me the motivation then to reach out and to try and investigate where is the link here, but we do need more research. So the breathing exercise, the first one that I'm going to have you do is to decongest the nose. It's very, very simple. Now, if any of the females are pregnant, please don't do it. If you actually do have obstructive sleep apnea, please don't do it. Or if you're doing it, go lightly. I don't want you holding your breath during the day if you're already holding your breath during your sleep. If you have any cardiovascular issues as well, please don't do it. But other than that, it's pretty safe. As individuals, holding the breath is a very natural thing to do. Anytime you go swimming, you're going to stay underwater for a period of time. But holding of the breath decongests the nose. Now, a very simple way to determine which nostril is more obstructed than the other is simply block one nostril and breathe through it. And then switch and block one nostril and breathe through it. So instead of the fogging test, we just have you do that. It'll give you some insight. And I would like you to practice this. Now, the key to decongesting the nose is to hold your breath for a period until you create a medium to strong air shortage. Ideally, it will be about 30 seconds plus. So the objective is for you to take a small, gentle breath in. I like everybody to practice it. A small, gentle breath in through your nose, a small, gentle breath out through your nose, pinch your nose, and gently nod your head, holding your breath. And continue holding your breath until you feel a medium to strong air shortage. Continue holding your breath until you feel a medium to strong air shortage. You can go easy on your neck, maybe just even move your body about, but at the end of it, make sure you breathe through your nose. Now, as you hold your breath, carbon dioxide builds up in the blood, and it seems to be carbon dioxide that's causing the dilating of the nasal cavity. But it's also activating sympathetic tone. Activation of the sympathetic nervous system may also be helping to decongest the nose, because physical exercise will open up your nose. If you do physical exercise, your nose will open. It will run a little bit, but it will also open. Now, you have to practice this 5 times, and I'm going to have you do it as a group, is to practice it 5 times. So you do it once, wait about a half a minute to a minute, do it again. Now, we teach this to children from 5 years of age upwards. In Hong Kong, I was in a hospital in the rounds, and a little kid comes in with adenoid face, and the whole face is sank downwards, and one of her nostrils completely blocked and the other nostril partially blocked. We had her do this. In 5 minutes, we can decongest the nose. It's very easy to decongest the nose. And what's more, when you start bringing breathing volume down towards normal, the nose will remain more permanently decongested. So let's try again. Take a normal breath in through your nose, a normal breath out through your nose, pinch your nose, and gently nod your head, and hold your breath, and hold your breath for as long as you can. I need you to hold your breath for as long as you can. So continue to hold your breath for as long as you can. Continue holding your breath. And when you feel a fairly strong need to breathe, to let go and to breathe through the nose. Now, another thing that can be quite useful there is when you hold your breath, you'll start to feel your diaphragm kick or contract. Because at some point, the brain is sensing there's a changes in blood gases. And the diaphragm is also sensing discomfort. So there's messages coming from the brain via the phrenic nerve to the diaphragm, and the diaphragm is starting to innervate. You're starting to give it a workout. If we go around with our mouth open, we primarily use the upper parts of the lungs. The diaphragm can become stiff. It's difficult to get in at the diaphragm. It's our main breathing muscle. But holding the breath can improve respiratory muscle strength by innervating the diaphragm. Can we try that exercise again? Take a small breath in through your nose, a small breath out through your nose, pinch your nose, and I'd like you to hold your breath, and hold your breath for as long as you can. So continue to hold your breath for as long as you can. And it's better if you move. It's better if you move. Hold your breath for as long as you can. I need you to experience the effect of, as you hold your breath, carbon dioxide is increasing in the blood, and carbon dioxide is helping to open up, dilate the nasal passages. So at the end of it, make sure you breathe through your nose and calm down your breathing. And I'm going to do it 2 more times. You can even check your nostrils there. Check your left nostril and check your right nostril. Some of you will start to experience some changes there after 3, but ideally you need to do it 5 times. Now, the individual who's coughing, when you hold your breath, you will have dilation of the lower airways as well. Mucus that's trapped will start to come up. But the other thing is, if you hold your breath for too long, and if you take big breaths at the end of it, the hyperventilation could just trigger the cough. But that's your symptom. It's easy to address it if you change your breathing. Can we try that exercise again? Small breath in through your nose, small breath out through your nose. Pinch your nose and hold your breath, and hold your breath for as long as you can. Hold your breath for as long as you can. And the key is to keep relaxing into your body as you hold your breath. Keep relaxing into your body as you hold your breath. To decongest the nose, you have to hold it for a medium to strong air shortage. For a medium to strong air shortage. Okay, so I would be comfortable enough. Just check one nostril and then check the other nostril. Is there anybody with quite severely blocked nose at the moment? You have. Can I try something else with you? Okay, would you mind coming up to the top? You'll be probably regretting it now. You don't have sleep apnea, high blood pressure, nothing, no?
No.
Okay. So if you block one nostril, breathe through it.
The one that's open or the one that's blocked?
Try. That's quite blocked. And try the other one. Okay, so the left nostril here is very blocked. Now, if it's a complete deviated septum or polyps, I can't do much about it. But if, for instance, the nose unblocking exercise that we just did, if that doesn't work, we try a different approach that's slightly stronger. By the way, can I just see those of you, a show of hands, who feel their nose is starting to open as a result of doing the exercise? So it's quite positive. It's better.
But it's still.
So I'm going to have you stand down, Richard. And I'd like you to just take a small breath into your nose. Now, by the way, no stress with this, yeah? So small breath into your nose, small breath out. Pinch your nose, and now walk as many paces as you can. Just walk as many paces as you can. And keep relaxing into your body. And maybe turn back up this way. And I need you to kind of push it a little bit. But at the end, don't overdo it, but make sure you breathe through your nose. Keep holding the breath. Keep holding the breath. Keep holding the breath. When you feel a fairly strong air shortage, let go. Let go now. Breathe through your nose, calm your breathing. Calm your breathing, and then you can just rest at that. And now try the nostril. Is there any change there?
It's improved.
Yes. So there's something physical there. And you know that. Well, I can't fix that.
It's not always as bad.
But thanks. Yeah, no, but that's... What we can do is we can help reversible obstruction or rhinitis, but if it's physical, and I'll explain it, but thanks very much. I have a deviated septum. It's very, very badly deviated. Dr. Hang can verify. He's done cone beams and he's looked and he says, oh my God, your nose is all over the place. But the human body is very resilient. When you change your breathing volume, you're not trying to force that big volume of air through it. When you bring your volume down towards normal, I'd say most of us here, to a lesser degree or more, have some deviation of the septum, you know, so it's very, very common. But doing this exercise here will work for somebody with chronic rhinitis. Now, it'll work temporarily. It's when you start changing your breathing, you'll get a more permanent change. Japanese study. Results suggested that breath holding increased the nasal volume due to shrinkage of the nasal membrane promptly and evenly within the nasal cavity. Now, of course, the paper is in Japanese, so I can't give you the translation there. This paper here, this is going back to 1923. This has been known for a long, long time. Nasal airway resistance was decreased during breath holding in man and during experimentally induced asphyxia in animals. Now, I've used that exercise on about 7,000 to 8,000 individuals, including children. We can get the nose decongested in 5 minutes. And if you practice that along with other exercises, including breathing through the nose, if you need to get your nose working, we have to breathe through the nose on a continuous basis. It's not just enough just to do the exercise. In this paper here, when nasal breathing takes place in the presence of significant obstruction, there's an increase in the pressure of carbon dioxide and a decrease in oxygen and a decrease in nasal airway resistance. In other words, if you've got a partially blocked nose and if you continue to breathe through it, the nose will actually start opening up. Now, it's easier for us when we're doing the exercises in tandem because you don't want to be, it's quite uncomfortable to breathe through a partially blocked nose, but generally one nostril is a little bit more blocked than the other and they'll change every 90 minutes. And when you lie down at night, the nostril that's closest to the pillow becomes more blocked. And that's why we switch position and we change it from left to right and vice versa. But breathing through the nose is key. Now, I wrote this in an airway forum, and I said it was my experience. I didn't have this paper at the time. I wrote it about a month ago, and I said it was my experience that when individuals start breathing through the nose actually starts working better. And there was an ear, nose, and throat there, consultant, and he said, in my 17 years of practice, he says, this is something that, you know, I have never seen. So in other words, he doubted me. But I have seen it with thousands of individuals, and even having just one paper, you know. But the key is, there's no side effects from teaching somebody to breathe through the nose. First do, no harm. Why is it so important to breathe through the nose? Is the link with rhinitis and sleep. Open mouth breathing during sleep is a risk factor for OSA and is associated with increased disease severity and upper airway collapsibility. And I think the relationship is quite strong. Sleep disorder breathing can both result from and be worsened by nasal obstruction. During sleep, this is an interesting paper now. This is a huge result, and I wouldn't expect such a good result. But during sleep, upper airway resistance was much higher while breathing through the mouth. In addition, obstructive, but not central apneas and hypopneas were profoundly more frequent breathing orally. 43 breathing through the mouth, and 1.5 breathing through the nose. Now, I had to look at that paper a couple of times to ask, is that actually correct? And that's what's published. Fitzpatrick's paper. He's based in the Northern Ireland Hospital. But here is another paper, and he's also involved with this. The treatment of nasal obstruction was associated with a dramatic and sustained reduction in nasal resistance and the oral fraction of ventilation during sleep. So there was an absolute reduction in the fraction of ventilation, breathing through the mouth, reduced by 30%. Now there was a modest change in OSA here, but the key here is the nose was decongested, but it doesn't necessarily mean that the individual was breathing through it. If you're decongesting the nose, we have to ensure that the individual is actually going to breathe through the nose. If we have the mouth open for a period of time, we develop a habit of oral breathing, we lose muscle tone, so when we sleep, it's very likely that our mouth is going to remain open. And towards the end, I'll give you a couple of strategies that may help, that we use in keeping the mouth closed. We have to ensure that the mouth is closed. Helping the nose isn't always sufficient. And here was one study, it was in Taiwan, and they looked at, we use a paper tape. And they looked at a paper tape, they called it a porous oral patch. 30 patients, they had greater than 5 events per hour, less than 15. All of them slept using the POP. The Epworth sleep scale before the tape was 8.1, and using the tape reduced to 5.2. The visual analog scale came down from 7.5 to 2.4. The median AHI reduced significantly from 12 to 7.8. Now that would be more of a normal result that I would expect. It reduced the AHI index by 33%. Now that's just breathing through the nose. That wasn't looking at reducing nasal resistance, and that wasn't looking at reducing breathing volume. And if you were to add myofunctional therapy on top of that, what sort of result would we get? Those are the key things. From my point of view, you're looking at airway, and I'm looking at what's going through it. Let's get the nose decongested. Let's get the breathing volume down, and let's get breathing through the nose. And add myofunctional therapy on top of that, and it will enhance the benefits. If we do nasal surgery, here 14 patients presented complaining of nasal congestion after previous nasal surgery, and they appear to have an adequate nasal airway, but no evidence of nasal valve collapse. They were evaluated for hyperventilation syndrome. Individuals that have a blocked nose for a period of time develop a habit of breathing too much. It's easier to breathe through the mouth than breathe through the nose. When they looked at the respiratory rate, all patients had an elevated respiratory rate of 18 breaths per minute. Upper thoracic breathing, because if you breathe through your mouth, you'll tend to breathe using the upper chest. 12 of the 14 patients complaining of nasal obstruction had an elevated Nijmegen score indicative of hyperventilation syndrome. Nijmegen questionnaire is a validated questionnaire to assess for hyperventilation. And on average, there was 2.5 procedures had been performed in each patient. My point here is, if we treat the nose, whether it's with nasal corticosteroids, whether it's with nasal operations, it's also important to look at the individual's breathing. If we have the mouth open for a period of time, we have to help that person switch from mouth to nose breathing, both in adults but also in children. So the conclusion was that hyperventilation syndrome should be included in the differential diagnosis of patients presenting with nasal congestion, particularly after failed nasal surgery. Or we could have showed these individuals how to decongest the nose in the first instance. I had a nasal operation in 1994. I continued mouth breathing. I continued having obstructive sleep apnea. I continued having asthma. And 20 years under medical care, not one healthcare professional said, "Patrick, breathe through your nose." That's regrettable. That's regrettable. How far do they know about this? Has anybody seen this advert before? This is obviously going back a long, long time. Stop mouth breathing and snoring. The perfect breather overcomes snoring and mouth breathing. And that's the message that we're trying to get. So I'm not here to criticize the CPAP, it works, but I'm here to show you this, because the CPAP is the gold standard of care. But one negative aspect of the CPAP machine is it can act as an orthodontic headgear and move the teeth in the upper and lower jaw backwards. You don't want that. You want to have the airway as far forward on the face as possible. We've heard it so many times. This effect can increase over time and may or may not cause TMJ disorders in some patients. These facial changes have been dubbed smashed face syndrome. This is a 2010 paper published in Chest Journal. Now, this is probably more relevant to children because they're more pliable to the effects of the lower and upper jaw being pushed in on the airways. And when we're looking at mouth breathing, I was looking at Christian Guilleminot's, at the papers that he has authored, because he is saying that if you breathe through your mouth up to 44% of the time during sleep, it's not an issue. But it is an issue if you breathe for a minimum of 44% and a maximum of 100% of your total sleep time. So that's his thesis on it. Now we would say we want the mouth closed 100% of the time. But I think it's interesting to consider that. And the persistence of mouth breathing, and Bill talked about that, Bill Hang, post-tonsillectomy and adenoidectomy plays a role in progressive worsening of the AHI index. He said it may not happen for 6 months, but it can frequently happen within 3 years. Now my daughter, I brought her because of course she has the same genetics as me. From day one she had a high palate. She's missing 2 incisors, which was revealed with scans. And she was displaying some symptoms of oral breathing, mouth breathing. I said, oh my God, it's happening in front of me. What am I going to do? So I went and we had tonsillectomy, we had adenoidectomy, we had lip tie done, we had tongue tie done. But the ENT never told us to breathe through the nose. And I sent on the papers to him afterwards. Because even though it's been published, the awareness of it, this is a 2015 paper as far as I can remember, the awareness of it hasn't got out there. And the treatment of pediatric obstructive sleep apnea and sleep disorder breathing, it means restoration of the continuous nasal breathing during wakefulness and sleep. Now we have to note, he didn't just say sleep. It's not just enough to get the mouth closed during sleep, we also need to get the mouth closed during the day. How you breathe during the day is going to influence how you breathe during your sleep. And as I said earlier, my daughter is missing 2 incisors, but if teeth are missing or absent or extracted early on in life, this can lead to bone retraction and affect the facial growth. You all know this. 257 people, aged 14 to 30 years, they had extraction of wisdom teeth. The patients had flow limitation between 50 to 90% of total sleep time, and the median apnea-hypopnea index of 7.5 events per hour. So if teeth are missing, after extraction of wisdom teeth, it's showing a risk with obstructive sleep apnea. Tetogenesis, 41 subjects, flow limitation for more than 50%, a mean apnea-hypopnea index of 7.3. And tetogenesis is a common disorder, and it seems to be increasing, and nobody knows why. It seems to be linked, maybe environment, epigenetics, but it's affecting 10 to 20% of the studied population. There's a genetic component to it. It's common to have one tooth missing, but 10% of cases will have 2 teeth missing. And in our children recognized with sleep disorder breathing, they had at least 2 missing teeth. But if you go back as infants, they were crying, labeled as having colic, sleep disruption, difficulty feeding, a Mallampati score of 3 to 4. In other words, they had very little space in the oral pharynx. A high narrow palate associated with a narrow maxilla. Again, the same features that you're so familiar with. When we were in Bordeaux, Christian Guilleminault gave us a talk, and he said, I quote, "We should look for whether teeth are missing early on in a child's life. This should be seen as early as possible. There's no doubt there are simple ways of seeing a lack of dental development, and this could be seen way before the sleep disorder breathing occurs." He said he talks of some of his patients coming in with OSA at the age of 40, but they were missing teeth. He said this could have been predicted when they were children. I predicted with my daughter, she's 6 years of age, and we are doing expansion with her to make room in her jaws, to put implants, to ensure that she doesn't have a life that I had. But I'm lucky. If I didn't have the information I have, she would have fell between the cracks. She would have been overlooked. Some of these people, as I said, were recognized with OSA at 40, and it should have been missing earlier on. If there's missing teeth, there's abnormal growth of the face and secondary decrease of the size of the upper airway. Prematurity. 400 premature infants, 292 indicated progressive development of obstructive breathing during sleep. It's very high, almost 3/4. Full-term children are also at risk, especially if mouth breathing. 2015 paper. So, some muscle activity, and I think this is really interesting, and you know, we did touch on it. Somebody spoke about having short frenulums. If there's a short anterior frenulum leading to abnormal feeding behavior and speech development, all children in the study with an untreated short frenulum had sleep disorder breathing. All had narrow palate. It's 100%. Short frenulum is, again, in Ireland, it was something that is not looked at. On the Irish Health Board website, it says it affects between 3 and 10% of the infant population. In other words, they haven't got a clue. And as it's not looked at, it's not considered in terms of the effect of short frenulum and feeding. If an infant has a short frenulum, they have difficulty feeding because they can't extrapolate milk from the breast. And breastfeeding is not just for nutrition. Breastfeeding is to allow the child to develop the muscles of the face to ensure good muscle tone. Nasal breathing starts from day one. But if the frenulum is tight, the baby is clomping on the mother is in pain, the baby isn't thriving, and the milk bottle is introduced. But it's so easy to drink milk from the bottle. The baby isn't going to go back on the breast where it requires work. And probably that's the first step where it all goes wrong. Rhinitis then is probably the second step. Rhinitis is nasal obstruction, runny nose, and it affects generally about 30% of the population. But frenulum is easy to deal with. I was afraid of my life to get my daughter's frenulum cut. I knew about it, but I was afraid of it. I did it when she was 4 or 5 years of age. But we still caught it fairly early on. So a short frenulum is something to look for. So breathe light. Now I'm going to have you practice the exercise, but before that I want to look at the relationship between stress and breathing. I think in adults certainly stress is a big aspect in changing breathing patterns. And how do you breathe when you're stressed? Does your breathing get faster or does it get slower? Faster. If you're stressed, will you breathe using your upper chest or your diaphragm? When you're stressed, do you sigh more or do you sigh less? You sigh more. When you're stressed, do you breathe more or do you breathe less? I know some people hold their breath, but generally we will start breathing more. We breathe faster, we breathe more noticeable, we often breathe through the mouth. That's how we breathe when we're stressed. But then we're often told to take a deep breath. What I'd like you to do is take a deep breath. So did you increase the speed of it? Yes. Was it like a big sigh? Yes. Okay, you're aware of nose breathing, so we're not going to have oral breathing here. But was it a noticeable breath? Yes. And if you were to look down at your chest, you'll see it's upper chest breathing. And taking the instruction to take the deep breath is endemic. You hear of it everywhere. We have this belief that the more air we breathe, the more oxygen delivered to the cells. But oxygen transfer takes place from the blood to the tissues in the presence of carbon dioxide. You breathe too hard, you get rid of too much CO2, and the bond between oxygen and hemoglobin strengthens. It's called the oxygen dissociation curve. But the other aspect is, light breathing through the nose, you harness a higher concentration of nasal nitric oxide. And nasal nitric oxide enhances oxygen uptake in the blood. To breathe through the nose, you activate the diaphragm. Activating the diaphragm and breathing through the nose will help activate the parasympathetic nervous system. The slower and lighter you breathe, the more you bring your body from a state of stress into relaxation. You need to do the opposite to the deep breath. And that's what we're going to practice. So what I would like you to do is, instead of breathing faster, I would like you to completely slow down your breath. Instead of sighing, I would like you to have regular breathing. Instead of breathing through the mouth, I would like you to breathe through your nose. Instead of noticeable breathing, I'd like you to have soft breathing. So I'd like you to put one hand on your chest, one hand just above your navel. And I would like you to tune into your breath. I would like you to feel the slightly colder air coming into your nose and the slightly warmer air leaving your nose. To feel the slightly colder air coming into the nose and the slightly warmer air leaving your nose. Can we influence your blood circulation through your breath? Pay attention to your body temperature and check, can we influence your blood circulation? As you feel your breathing, I'd like you to pay attention to the airflow as it comes into your nose and as it leaves your nose. And I'd like you to start slowing down the speed of the air as it enters and leaves your nostrils. Not to hold the breath, not to freeze your breathing, but to gently soften the breath, to slow it down, and to slow down your breathing to the point that you feel that you're not getting enough air. Can you slow down your breathing to the point that you feel you would like to take in a bigger breath? So you're following the airflow coming into your nose, you're following the airflow leaving your nose, and you're deliberately just gently softening it and slowing it down. But to slow it down to the point that you'd like to take in more air. It shouldn't be stressful. It should feel the same as if you're going for a light walk. And as you slow down your breathing, carbon dioxide gently accumulates in the blood. So I'd like you to also think of harnessing nitric oxide in the nasal cavity. The lighter you breathe through your nose, the higher the concentration of nitric oxide that you bring into your lungs. To breathe so lightly, so quiet, so calm, and so soft. If your attention wanders off, bring your attention back onto your breath. Breathe so softly, so light. You're only doing this correctly if you feel that you're not getting enough air. We shouldn't see anybody breathe. So I'd like you to slow down your breathing to the point that you feel that you'd like to take in a larger breath. that you feel a deprivation of air. Continue slowing down the breath. Continue slowing down the breath. Continue slowing down the breath. Two things to pay attention to: the amount of saliva in your mouth and your body temperature. Okay, so we can take a rest for that. I'm going to take a rest just for a minute. By the way, how many of you had an air shortage? How many of you felt you would like to take in a bigger breath? Okay, cool, it's quite a few. Okay, so I'm going to wait a minute. I'm going to try a slightly different approach. I can't really pay a whole lot of attention because there's so many of you here. But I'd like you, for the next one, is just to check which nostril is more blocked. Is it your left or is it your right? And what I'd like you to do is I'd like you to block your blocked nostril. So the one that's more congested is to block. And to breathe through your free nostril, but to start softening the breath as it comes through your free nostril. So now we're narrowing the concentration of air to one nostril. Can you breathe so quietly, almost as if the fine hairs within the nostrils do not move? You're tuning in to the airflow as it comes into your nose, and you're feeling the airflow as it leaves your nose. You feel the airflow as it comes into your nose, and you feel the airflow as it leaves your nose. And you're gently softening your breathing to the point that you feel that you're not getting enough air. Lao Tzu, he said that the perfect person breathes as if they do not breathe. Can you breathe so lightly to harness nasal nitric oxide, to carry it into your lungs, or to help open up the airways, sterilize the air, improve ventilation perfusion? Breathing so soft, so calm, so quiet. So I'd like you to continue for one more minute, following the breath, feeling the airflow as it comes into your nose and feeling the airflow as it leaves your nose. If your attention wanders off, bring your attention back onto the breath. It's a very good exercise to follow your breathing. Take attention out of the mind onto the breath. Out of the mind onto the breath. Gently soften your breathing. Gently quieten your breathing. Gently calm your breathing. And the only thing you have to do is you're paying attention to the airflow coming into the nose, you're paying attention to the airflow leaving your nose, and you're gently slowing it down and softening it. Gently slow it down and soften it. Okay, so we can take a rest at that. I'm just curious, as a group of people, now it's not going to be 100% or anything like it, who feels a change in the amount of saliva in the mouth? Is your mouth drier? Is it the same, or is it more moist? It's more moist. When you get stressed, how does your mouth go? Dry. So it's activation of the sympathetic nervous system. When we do deep meditation, how does our breathing change? Our breathing goes down to almost nothing. If you were to meditate for 3-4 days in deep meditation, you'll find that your breathing, your metabolism drops, your breathing reduces, everything changes, gets softer. On the basis that stress makes people sick, relaxation and reduced breathing will help to make them better. When you focus on your breath and you deliberately start softening the breath, you activate the parasympathetic nervous system. You experience increased watery saliva in the mouth. That's generally accepted as activation of the PNS. You can bring your body from a sympathetic tone, from being switched on to being switched off within about 3 to 4 minutes by slowing down the breath. It's the complete opposite to the deep breath that's usually instructed. It's absolutely vital to breathe through the nose to help people if they're in a state of stress or anxiety. Mouth breathing is going to only contribute to these issues. Has anybody experienced a change in body temperature? Are you colder, warmer, or the same? Okay. Now some of you may have felt a little bit colder if you overdo it, because it activates the sympathetic. If the air shortage is too much, a stress response happens. It's a fine line between having air shortage and stress, but that takes practice. And I'm limited here that we can't give you all that much feedback. But there's only 2 ways to do it. One is that you're following the airflow coming into your nose, you're following the airflow leaving your nose, and you're gently softening your breath as the air enters and leaves your nostrils. The second way is that you take a shorter breath in and a gentle, relaxed breath out. But the key is to generate air shortage. If you don't have air shortage, you don't get the same effect. The air shortage is the key to resetting the breathing center. Remember, we spoke at the start, we said that people with asthma are breathing too much. People with obstructive sleep apnea are breathing too much. People who snore are breathing too much. Modern life is causing us to breathe too much. How do you change it? By doing that exercise. By breathing through the nose and by deliberately reducing your breathing to reset the respiratory center in the brain. And if you were to practice that for a certain amount of time every day, you'll gently reset the breathing center. Your breathing becomes lighter, both during the day and also during sleep. And in terms of sleep, you've got less negative pressure in the upper airways. You'll have less inflammation of the upper airways, less inflammation of the lower airways, less obstructive sleep apnea. Obstructive sleep apnea is not just about airway size. You cannot consider OSA by just considering the airway. You have to consider what is going through it. So what are we looking at? We're looking at three things. Amplitude of the breath. We look at it with our eyes. We don't use equipment. I look at an individual's breathing and we get a sense of the amplitude of their breathing. We get a sense of the respiratory rate. How fast are they breathing? Are they breathing using upper chest or using diaphragm? We also look at the natural pause between breath. What's the length of time of the natural pause? Good breathing, you've got a nice natural pause between breaths, generally 3 seconds, 4 seconds. It's not put in. A person who's breathing heavy have no natural pause. They have a larger amplitude. They have no natural pause and they've got a relatively faster rate. As soon as they breathe out, they have to breathe back in again. But as you change your breathing, the breath becomes softer, the respiratory rate will reduce, and the natural pause will increase. Breathing then is lighter. And with practice then your control pause or your breath hold time increases. So when you're practicing it, the key is to have a tolerable air shortage but not to be stressed. We don't want stress. I put just a connection. I was trying to put a connection between mouth breathing and TMD. Is there a connection between mouth breathing and temporomandibular disorders? And in this paper here, it's a 2005 paper. It's published in the Journal of Clinical Pediatrics and Dentistry. And it looked at, the neck accessory respiratory muscles and mouth breathing suggest a direct relationship among asthma, temporomandibular dysfunction, and cervical spine disorders. So this study was performed to evaluate and correlate TMDs, the cervical spine disorders in asthmatic and non-asthmatic, to see if there's a relationship between your breathing and TMDs. 30 asthmatic children, 30 non-asthmatic children, predominantly mouth breathing. So you had a mouth breathing group and you've got an asthma group and you've got 30 non-asthmatic, predominantly nasal breathing. So you've got 3 groups of kids. The significant frequency of palpatory tenderness of the temporomandibular joint, TMJ sounds, pain during cervical extension and rotation, palpatory tenderness of the sternocleidomastoids and the paravertebrae muscles, and a severe reduction in the cervical range of motion were observed in the asthma group. Now, asthma group will tend to be mouth breathers in the main. But there was a relationship between the asthma group and the mouth breathing group of kids. They demonstrated palpatory tenderness of the posterior TMJ, medial and lateral pterygoid, trapezius muscles when compared to the nose breathing group. The results suggest a positive correlation between the severity of TMD and the CSD signs in asthmatic children. There seems to be some relationship between oral breathing during childhood and TMD. Now, many of you spoke about forward head posture, the alterations to the craniofacial changes, but there's a lot going on. The nose is not just the 2 holes in the face. No child was considered normal to CSD and cervical mobility. The possible shortening of the neck accessory muscles of respiration and mouth breathing could explain the relationship observed between temporomandibular disorders in asthmatic children. So I'm going to wrap it up with a brief study that we did 3 years ago in Ireland, and then we'll have about 15 minutes for questions or so. And the study looked at 26 volunteers. It was conducted by the Department of Otolaryngology at Limerick Regional Hospital. I was brought in as the instructor, and they used 3 validated outcomes. They used the nose, which was developed at Stanford, and the nose evaluation survey. It looks at nasal congestion or stuffiness, poor sense of smell, snoring, nasal blockage or obstruction, trouble breathing through the nose, trouble sleeping, having to breathe through the mouth, unable to get enough air through the nose during exercise or exertion, and feeling panic that you cannot get enough air through the nose. So the nose survey was used, the snot test was used, which is the sinonasal outcome test, and the visual analog scale. I think you're all familiar with the snot 22 test. You use it here in your ENTs. So before teaching, the exercises was in blue, and 3 months follow-up was in red. So across all 3 validated outcomes. Now, what did we teach? I taught the exercise to decongest the nose. We taught about the importance of nose breathing 24/7, not just for brief periods. Nose breathing both during the day and nose breathing during sleep. We taught different exercises, including the exercise that you practiced. Now, you're probably wondering, how did we get the mouth closed at night? We use a simple paper tape, but it can be a little bit controversial. So I'm going to show you another product as well that's just coming on the market, and I have absolutely no financial interest. But the paper tape, I started using paper tape in my mouth in 1998, and I never stopped. It has given me the best night's sleep. When you're sleeping with a mouth open, you don't have a good night's sleep. You don't have a good night's sleep. You'll tend to wake up more fatigued. You'll tend to be more tired during the day. Most certainly the quality of sleep is affected if the mouth is open. The paper tape we use is 1-inch micropore tape. Simply dry the lips, and you could either place it that way or place it that way. That can sometimes raise eyebrows. There's a product now that's just come out of Australia. It's only come out 2 weeks. Now, I'm not sure when it comes to the USA. It's called Sleep Q. I think it's a very interesting product in that it's going to make our job a lot more easier. Because oftentimes the criticism, oh my God, you're asking me to put paper tape on my mouth. Sleep Q is like a tube of toothpaste. You squeeze a little piece of it out onto your finger and you put it on your lip. You press your lips together and it sticks your lips. It's sticky food. And it's it's pharmaceutical grade. So this will come out, and I think it will make our life just a little bit easier.
Kind of like super glue.
Super glue. So overall, the reduction of symptoms that we did at 3 months follow-up were 72%. Now this is without nasal corticosteroids. This is without operation. This is only teaching the body to help itself. Looking at the relationship between oral breathing, heavy breathing, and how it's contributing to nasal congestion. A number of things that I want to leave you with. We have to increase the awareness of the importance of nose breathing, both in childhood and in adults. We also have to look at breathing volume. If an individual walks into your clinic and they've been mouth breathing for a period of time and are having noticeable breathing, and you sit them down and you simply measure how long can they comfortably hold their breath for, or they may be sighing regularly. The rule of thumb is, if you can easily see a person breathe during rest, they are breathing too much. The 3 things that we look for in the breath: the amplitude of the breath, the respiratory rate, and the natural pause between breaths. You want the amplitude to be nice, light, soft, and easy. You want a natural pause between breaths, and you want a normal respiratory rate. That is good breathing, and it's easy to fix. We would expect snoring symptoms to reduce by about 75% in 2 weeks. But minute volume has never been measured. It's only been measured once in obstructive sleep apnea. All of the studies have focused on airway. We really have to look at the other half of the picture, and that's breathing. So, thank you very much. If you have any